And I'd like to go ahead and welcome Dr. Victor Dzau, who's president of the National Academy of Medicine, to the stage.
Where would you like me to sit?
Wherever you're comfortable. How about right here? So this title speaks for itself. We're going to be talking about breakthroughs in medicine and how we can ensure that everyone can benefit from those breakthroughs. And Dr. Dzau, for those of you who are less familiar, a lot of your background has to do with cardiovascular medicine and genetics, and many of the innovations you've worked on are still not broadly beneficial. They benefit people who at this point can afford them. Now, there are advancements happening in this space, but you are now at the National Academy of Medicine doing a lot of work to ensure that these breakthroughs, whether it's in gene editing or whether it's in AI, can be broadly beneficial. So let's start with the breakthroughs, and then we'll talk about access. When it comes to breakthroughs in medicine, what are some of the advancements you're most excited about?
Can I give you a minor correction?
Sure, please.
So some of my work, I'm not the only one, but I'm among those who led to the development of ACE inhibitors. Mm-hmm. As you know, that's for high blood pressure, heart failure. That's kind of my claim of fame. Mm-hmm. But I've gone on to work on many other areas, such as genetics, gene therapy, and others. But you know, when I think about this whole issue about the future first of health, you could argue that innovation creates tremendous excitement and possibilities. I look back 50 years ago, and one can say, the global life expectancies increased by 25 years with better drugs, better hygiene, you name it, right? We didn't have, look at COVID-19, we didn't have the mRNA vaccine that came around. HIV is now a chronic disease and it's curable. And of course, I can give you the long list of possibility. So I would say innovation is really the future, has to be coupled with equity and good policy, no question about this. So if I look forward, how many people have read the book by Huxley on the Brave New World? You guys are too young to, this is good. 1930, Huxley said, I can envision a society with genetically modified human being with intelligence, hierarchy, you name it. We're here. Today, we can have gene editing. We have AI. We can do manipulation of, misinformation, psychology. But on the other hand, I can imagine that we would have the tools that can really, really start making a huge difference. And there's no question in global health, innovation has to be a big part of the solution. One last point. Cheney Zuckerberg, many of you know about Cheney Zuckerberg, right? In 2018, when they launched their big initiative, they asked the question, by the end of the century, we will have cure, manage, or prevent all diseases. Let me see a show of hands. End of the century, almost 75 years from now, will we have cure and prevent or treat all diseases? Anyone? You're wrong.
I was going to say, for those tuning in online, no one raised their hand.
Yeah. You know why you're wrong? Look back 80 years. I'm in my 70s. I can tell you, forget the internet, forget the drugs, forget all those things. Even as I was training in cardiology, we had, for heart failure, we have digitalis, which doesn't work, and diuretics. Today, we have armamentarium of, anti-obesity drugs, things that you can never imagine. And that happened in the last decade only. So down for the 80 years. I think the big question should be, would everybody benefit from it? That's the equity issue. And I think in global health, that's what we need to focus on. How do we make sure everybody can have access and benefit from all the advances?
So speaking of ensuring everyone benefits, and let's just narrow in on one example of how rapidly things are advancing, CRISPR. So maybe another show of hands, since it's always helpful to read the room. How many people are familiar with CRISPR? Okay, there's some familiarity here. Still relatively new, and I'd love for you to speak, Dr. Dzau, to what a game changer that is. And when it comes to CRISPR, for example, how can we make sure that it is broadly beneficial and could reach everyone?
Yeah, so it's not new, of course, when you think about gene therapy. But the days when I started working on it we can only imagine that we can either put in a gene that either replace something that's missing or, in fact, amplify its product. But it doesn't target itself to the genetic mutation. CRISPR has the ability to do that. Using a guide RNA, it can go directly to where the sequence abnormality is, clip it off, and replace it with a new gene. So, in fact, CRISPR, therefore, can cure diseases. Now, there are two types, of course, you can imagine. One is germline, the disease that you inherit, right? The germline, where you can actually change all the cells at the time of, in fact, conception, using IVF approach, right? Or somatic. People are using it for HIV treatment, right? Targeting the receptor in which the HIV virus enters the cell, you can actually change those receptors, and therefore you can get it. So CRISPR is really game changer, which is why it got the Nobel Prize, right? But where we are in CRISPR, of course, is still the early stages where we're doing different trials. Many of them are somatic, treating cancers and others. And of course, in germline, as you know, there's a lot of controversy, and we're among the academy to say, don't do it yet. Mm-hmm. In fact, in Hong Kong in 2018 is our meeting in Hong Kong with the Royal Society when the Chinese investigators say, I produced twins. And of course, we're just not ready. It's not only, it is an ethical issue, to be sure. Also, technologically, it's not quite there yet. We don't know what long-term effect is, et cetera, et cetera.
These were the twins who their DNA was edited to prevent HIV infection,
exactly.
For those who are less familiar. So in terms of getting from aspiration to reality, to really ensure that these tools reach low-income populations, and it's not just, we've talked about gene editing. Another big example when we talk about AI is medical imaging, for example. That's a huge use case that could be so broadly beneficial. What are some of the partnerships emerging that are actually delivering on that? I want to make sure that in this session, we don't just advocate for the need, but highlight some real examples of partnerships.
To begin with, I worried a lot about inequity. I mean, if you look at gene therapy, $2 million, $4 million for treatment. So you can imagine who can afford those kind of treatment, right? If you take sickle cell, which in fact 80% is in Africa, you have now the ability to cure sickle cell, but who's going to benefit from it, right? So clearly we're not there yet. I think there are really two important issues in my mind, or several. One, of course, is a market-driven approach to innovation is simply not sufficient. We need mission-driven approach, right? So in America, the products get to market, get to develop because there's a market. I can charge enough to do it versus there's a need. So I think we need to change the outlook altogether. And of course, secondly, is the whole issue of access as well, not just the cost of it, but the delivery to it and whole bit. And so here's where policies and many other issues are going to be very important.
So I would love some specific examples of policies that could make a difference. Here we are at the World Health Assembly. One example of something that I understand could make a big difference is the WHO has its lists of essential medicines, and that prioritizing innovative therapeutics as part of that could be one example of an important step forward. Can you talk more about that?
Yeah, I think it's really important that we have a strong voice about this issue. I mean, after essential medicine, I kind of look back and think about HIV. The early days HIV, actually people who argue that everyone should be treated, we're saying, wait a minute, you're taking money away from public health because it's too expensive. You only cure a few people, to the fact there's a whole activism, there's PEPFAR, there's all these things that make it happen. The same go for all the medicine, in my opinion, that people need to look at the global needs and put real pressure, in my opinion, on the pharmaceutical companies and others to make these accessible. And hence, essential medicine is a really good example. Now, you talk about public-private partnership, you asked me a partnership. I think it's really important to pull in, because after all, you think about this, innovation is going to happen by scientists. But what happens is you can't get to human unless you scale to, randomized control trials, development, approval and commercialization. And that's where the gap is, that is you push it over to the other side when in fact there's no particularly focus on equity. This is where I think public-private partnerships are really important, because at the very beginning, you have to ask the question, are we making these drugs for only a few? Are we making it for everyone? And I can tell you that the CEOs of farmers and devices are saying the right things. I'd like to see them really doing the right things. So they talk a lot about access, talk about equity, but the question really is, what does that really mean, particularly in low-income countries? So there's a lot of work need to be done.
And of course, in terms of the stakes, yes, we talk about how it's important that everyone benefits. And then if everyone doesn't benefit, these technologies actually worsen inequity, right? And that's what you're trying to address. Can
I say something? I think it's really important to think about innovation as everywhere, not only rich countries.
Absolutely.
Right? Some years ago, I started a NGO equivalent with Wellcome Forum, McKinsey, and Duke, which is called Innovation Healthcare. What we're looking for is all the innovation in low resource settings, to say, how do they solve this problem, and how can we bring it to, other places as well, and scale and replicate. I think too often we think about low-income countries incapable of doing research, which is absolutely not true. So building capacity is really important. Innovation ecosystems as equitable, getting people who are doing local research, understand the local needs, and in fact, building the local capacity. AI is a really good example, right? If you look at all the AI information, they come from large set of data sets from people, in the United States and elsewhere, and mainly from white men and some white women. It doesn't quite apply, as you know, to the population like myself, Asian American, or African Americans and elsewhere. So what you need to do is really collect that data locally and being able to use the right algorithm to have that information to be applied locally. So my feeling is that you got to take innovation to the ground, develop capacity, and ask the question that's needed for the local purposes community, and of course develop the trust along with it.
Absolutely, agreed. And we will be highlighting a lot of innovations from the African continent in our programming today. I want to just better understand, as we move toward a close, what exactly the National Academy of Medicine is doing to integrate equity in the innovation ecosystem. That's really what you're calling for. What are you doing on that? And what are you looking for in terms of partnership, maybe even from people in this room?
You mean time's up already?
We're getting there. I know. There's so much ground to cover.
Okay. So we've been very, very focused on this issue. And one important thing is we had a report that came out last year that says what you need to do is embed equity into an innovation ecosystem. Because when the average researcher comes to a lab, they're just interested in finding out things, what makes them excited, got more grants, and maybe make them famous. But they never think about, what if this tool is being used for treatment, and how would it be equitable to everyone? That includes a culture of equity in thinking, in training, in design of clinical research. Think about the population you can be studying, right? And think eventually in a university environment, who am I going to license that information to, right? The licensing officers say, let me make as much money as we possibly can. But I actually feel, and that's what we're working on, that universities think about how would the companies that would license it assure me there's equity in terms of pricing, you name it. It's a starting point, right? So we do a lot of that. So we also think about, what about funding agencies? Should funding agencies have a question about, when you do this research, have you thought about what it means? Well, more and more people are asking about diversity. Why not the issue of equity as well? What about journals asking? Now, journals are now asking about populations. In women's health, they are beginning to say, let me look at your data and disaggregate it. We could ask the same question about, have you considered equity? So once you develop a culture of equity, then the whole innovation system will be thinking along the way to say, how can we do good versus how we can do better.
Well, thank you, Dr. Dzau. There's been a lot of conversation on the importance of equity and innovation, and I appreciate you helping us see the path there. So thank you for your time, and I'll welcome Kate back to the stage.
Okay, but I don't want to ask 8 years from now, okay? You're going to come and tell me, you know what, you're right.
We'll see. We'll have you back. We'll have you back to have that conversation.
Thank you.
Thanks, Dr.
Bye.
Dzau.